All right. Hello, everyone. Welcome. We'll give everyone just a couple seconds to join us and filter in. Hello, welcome, welcome. I see everyone joining. Welcome. All right, so we're going to go ahead and get started. So today you're going to be hearing from Vheda Health on boosting health plan quality ratings, data-driven strategies for medical, Medicare, and SNP success. Before I turn it over to today's presenters, I do just want to flag a few housekeeping items. So you will notice that your cameras and mics are going to be off for the duration of the webinar. This is for your privacy, but if you do have any questions, please, we encourage you to put those in the Q&A box found at the bottom of your screen. The team is going to do their best to answer questions, if applicable, throughout the presentation, but most will probably be saved towards the end. But if there's any that they can't get to, don't worry, they will reach out to you directly after the webinar to follow up. I do want to flag as well, you will be seeing a few polling questions throughout the webinar. To answer these, a box is going to pop up on your screen. All you have to do is just select your answer and hit submit. So no need for the phones or QR codes to submit those. After today's webinar, you will be receiving an email from Rise the following day with the access to today's recording as well as the slide deck. So without further ado, I'm going to turn it over to Bill to get us started.
Well, we're excited to welcome to the Vheta's educational series today. In this session, we will discuss the clinical and health perspectives and address the critical role of quality ratings in Medicaid, Medicare, and SNP success, special needs populations. We expected a dynamic discussion of real-world data, actionable strategies, and human impact of ratings in communities we serve, including rural and hard-to-reach areas. And I'd like to introduce two of our speakers. Beth Markley, RN, MSN, Clinical Strategy Manager at Blue Cross Blue Shield of Illinois, provides world of information, worked as a trauma nurse, and understands and great insights on quality rating challenges and solutions. And Dr. Sheila Woodhouse, Senior Medical Director of Vheda Health, Clinical Perspective and Quality Improvement. Today, we're going to look at expanding the experience of bridging financial imperatives and members' outcomes. Our aim is to show empathy in every case and provide takeaways that benefit both patient health and financial stability. We'll walk through why quality scores matter beyond dollars, driving access and accreditation, contract pressures and clawbacks, which is very important in today's environment with Medicaid and Medicare, case-based focus on CBP and A1C impact and workflow integration, Vheda's repeatable, scalable blueprint, key takeaways and open Q&A, including case studies. Everything that will be discussed today will be from the real-world results, data, not theory. With us, Dr. Woodhouse, the Senior Medical Director, and Beth, Clinical Strategy at Blue Cross, will evaluate Vheda's help and help plan clients. Beth will share exactly what works with Blue Cross and insights on high-stake environment. One of the questions we want to present to start with for all of you to review and look at is, how confident are you in your health plan's approach to improving quality ratings and outcomes for rural and hard-to-reach communities, access with Medicaid, Medicare, and special needs populations? A, are you very confident? B, somewhat confident, but could improve? Just starting to address, not addressing it yet at all. So we look forward to those poll questions. Can we go to the next slide? High level importance and quality scores. Dr. Woodhouse, let's start at a 30,000 foot level. Why do quality scores matter and more now than ever?
Yeah, thank you, Bill, and welcome everyone. This is exciting for me because I believe the paradigm of healthcare is shifting significantly because now we know what to do with the data. So for me, quality scores are far more than just metrics. They really have the capability of reflecting real world patient behaviors and system coordination that ultimately impact the health of patients. Being able to access and leverage the right data to drive improvement will enable us to expand with precision, and we'll talk about that a little later, and deliver the best care for improved outcomes at scale. We must keep quality metrics and data at the center of patient-centered care. We use that word often, but now we can contextualize it into its relevance, not just for compliance or bonuses, but really to improve lives across communities, especially in underserved and rural areas. So for me, the bottom line is that the better the scores, the greater the resources to prevent poor outcomes, the greater the patient's health, their satisfaction, and ultimate engagement, which in turn leads to real-world progress in equitable health care and improved outcomes.
Thank you very much, Dr. Woodhouse, for your insight. Beth, provide us your perspective on why quality scores matter more now than ever.
Yeah, thanks, Bill. So at Blue Cross Blue Shield of Illinois, quality scores really have a direct impact on our ability to win new contracts, secure expansion in our existing states. And when we achieve our high quality scores, it also allows us to staff our existing programs. When we miss those targets, things that are put at risk include things like our P for P withholds, and they actually can result in penalty clawbacks. So for us at Blue Cross, quality is not just a year-end goal, it's really built into our overall daily operations. Ultimately, from a health plan perspective, our strategy and our reputation really depend on achieving those measurable improvements for each one of our members that we serve.
Thank you for that valuable insight. I think too, within a health plan side, with the new CMS rules and Medicaids and states forcing more quality for you guys with less resources, it's very imperative that you hit those. So let's examine another part: contract pressures, managed care, P for P, and clawbacks. How are contracts, provider accountability, and P for P models raising the stakes for the health plans and for providers? And I think it's a big challenge now. But Beth, if you could provide us your overview on your plan's approach to these, questions and concerns.
Sure. Thanks, Bill. Most of our state contracts have some sort of pay for performance incentives and value based contract requirements. And like I said, if we miss those defined thresholds, the state can withhold capitation dollars, which for us at Blue Cross could actually be upwards of millions of dollars. Other states that we have contracts in actually claw back payments, and that can be either done through monetary penalties or even frozen membership for our enrollment purposes. Hitting those benchmarks actually helps us earn our bonuses and actually will solidify the auto assignments for us as a health plan. In addition, the provider level value based contracts are really critical. And in Illinois, we are actually moving most of our providers over those type of incentive models, which actually will tie outcomes to both collaboration and accountability. Um, Increasingly, we've seen both collaboration and individual provider contracts actually hold all parties responsible for real measurable results. It's not just an attestation any longer that outcomes have been achieved. The outcomes have to be defined and demonstrated by our contracted providers to us as a health plan.
Thank you, Beth. But I have one other question. In Illinois, for your pay for performance program, does the state require you to achieve all quality measures to hit your bonus? Or is it weighted and measured by just certain quality measures that you hit?
So in Illinois, we've actually got a couple different segments of the P for P and P for R. So P for R is a specific defined measures that are for reporting purposes only. So we have to report those to the state in the time frame that they require, and then we will hit those. Those are weighted, as are the P for P measures. Those are also weighted. So for Illinois, it's not an all or nothing. Some states I know are all or nothing, but in Illinois, as long as they've got the defined thresholds for the P for P dollar, or yeah, for the P for P measures. And as long as we've hit them, we will get the money back. But it's not an all or nothing. It can be segmented out to partial payments.
Thank you very much. Dr. Woodhouse, would you provide us your perspective on these contract pressures, especially from a provider side, and then look at P for P as well?
I love this question because I think in this era, normally providers would mute and camera off and run the other way and beginning to talk about these pay for performance. But I think we realize now we know we need to engage because we're in here, we do what we do to improve outcomes of the lives of patients that we care for. So these models to me are raising the stakes by linking dollars directly to outcomes. And it's no longer enough to just deliver care. And I think providers know this. Providers and plans are now measured on engagement, adherence, and sustained improvement across populations. The new regulations that you reference and things like the chronic care collaboration for star ratings in 2026 really make real-time measurements vital. And I think that's some of the jab for providers, because when you say that, how do you accomplish that? But by innovative technologies and data analytics, it means we can now validate outcomes from both health plans and provider perspectives. This is essential for showing that the pay for performance and value-based contracts drive intended performance and really measure what the physician or providers are doing. Data-driven care delivers not just compliance, but optimal patient outcomes and financial protection for all parties.
Thank you for your insight. And, too, I think with this part, that we need to address is the medical loss ratios, especially the health plans have to look at it. And if the plans underspend on member care, readmittance, Beth, as you said, payments are required, can be a penalty, hurts your profit, enforces appropriate reinvestments into members. So you really have to measure all of those. And it's such a moving target for you guys. It's very tough for both sides, providers and for the health plan. Thank you both very much for that insight. So let's look at member case study on focus on CBP and A1C. Some HEDIS measures are more in your control than others. We would look at why is CBP and A1C clinical priorities and strategic levers for health plans and providers so critical. Dr. Woodhouse, from your perspective, could you look at it from a provider side?
Sure, especially as a cardiologist, a practicing cardiologist, you deal with trying to control blood pressure and mitigating risks that lead to heart disease. So controlling blood pressure and hemoglobin A1C are not just, again, boxes to check. They actually drive downstream outcomes and cost savings for patients, communities, health systems, and plans. Managing these measures lower the risk of stroke, heart attack, kidney failure, and other long-term complications. The impact of blood pressure and diabetes, if uncontrolled, is compounded exponentially across a member's life. So by reducing their risks of these key metrics, by closing any gaps in care that would limit the patient in achieving their goal, standardized goals for blood pressure and diabetes, is critical. Not just during the month of their doctor's visit, but over the course of time. This often requires precision engagement and predictive analytics. Precision engagement means engagement specifically to that population, those patients in a certain area with certain other comorbidities. And I say comorbidities not just in disease state, but in environmental, social, and economic influences. And predictive analytics can identify which patients are at high risk for missing follow-up appointments, not taking their medications, not refilling their prescriptions, or going for their routine screenings. They can be targeted with proven interventions, often using technology, and education about those risks.
Additional question, Dr. Woodhouse, have you found it hard to get members back in to look at, taking their blood pressure and their A1Cs, and how are providers looking at, engaging them more from that perspective.
Bill, I wouldn't say it's hard to get them back in because now there's leveraging telemedicine and using physician extenders. I think the challenging thing is getting the right data at the right time to make the right decisions. So I think when you have technologies that interface between providers' offices or health systems as well as the patient in their community and their home, then it gives the physician kind of that timeline. Where do we need to kind of further kind of direct our visit or our interaction, whatever format that's taken, whether virtually or in person? And so I think that's where the critical gap is. Clearly, some patients will not follow up, but again, I think now after COVID, there's multiple ways to follow up with patients, but it's about the information that they have and how reliable that information is in order to manage that patient.
Thank you very much for that insight. Beth, love to hear from your perspective.
Yeah, so, like Dr. Woodhouse mentioned, getting these members to help manage their conditions is really imperative. And so here at Blue Cross, our playbook actually starts with Vheda for these. These quality scores, like I said, don't just secure our bonus dollars, they actually shape and help define how we staff and invest in our member benefits. I have a great example of something that, where a member was very engaged in trying to manage her conditions. Back in May, this member actually transitioned from a different health plan over to Blue Cross Blue Shield of Illinois. And when that member was at their prior health plan, they really relied heavily on the Vheda program and that dedicated phone to manage her diabetes and hypertension, as well as, of course, support from the member engagement or member experience team, I should say, and her caregiver. When she transitioned over, the member had actually reached out to the Vheda staff because they were very deeply distressed about the thought of losing access to the Vheda program and her cell phone. The member was very concerned about the program's termination. She expressed repeatedly to the Vheda team, "I desperately need my cell phone. I need it to manage my chronic conditions, and I absolutely can't function without the Vheda program." So at that time, of course, we all recognized the urgency for the member to remain in the program, and the Vheda team immediately reached out to me, and we coordinated this, between them, the Vheda team and myself here at Blue Cross Blue Shield. Together, we were actually able to ensure she had a seamless transition. She maintained program access and continuous support for her without any type of service interruption. And this type of experience really does underscore how vital these clinical tools are and how proactive care coordination is for members who are managing these high-risk chronic conditions. In this case, this scenario also demonstrates that responsive teamwork, data-driven engagement, really they do have a direct impact on real lives and health outcomes. Within the Vheda program, the members have access to, the very condition specific tools, which then will help them manage their chronic conditions. There are some examples of these devices, including like internet enabled blood pressure cuffs, glucometers, those are all deployed at scale. Devices that, send clinical readings in real time. So then for any member that might have an outside of their normal reading, the Vheda nurses then can flag them as outliers and they can intervene on that same day. The Vheda engagement platform is also both culturally and linguistically tailored and uses a multimodal outreach and continuous follow-up. Obviously, the goal then is ultimately to build the skills necessary for that member to sustain health improvement over their lifetime and effectively manage their condition long term. So, from a health plan perspective, success for us means year over year increases in our HEDIS rates, such as CBP and A1C, and obviously to control their chronic conditions. And it's no longer just a baseline compliance, it's not a check the box. It really is a true focus on long-term stabilization of chronic conditions. And really that's how the clinical role of the Vheda team and us as a health plan are able to, intersect consecutively, and have, unite us together.
Yeah,
Thank you very
Beth,
much for that perspective. And I think both of you talking about the technology of how it can help being in home and help providers actually reach out to their member too. That was a great contributor to both of those on this. I appreciate that very much. Let's look at the next slide. Really, we look at, gaps in care and closures of those and the obstacles. So beyond CBP and A1C, what gaps remain that are vital to health plans and to providers that, these programs can have huge success on? Beth, I'll go to you first.
Sure. So we actually have primarily three major obstacles from a health plan perspective. We're still seeing low preventative screening rates, particularly in areas of the state where there's either rural or high need regions, where access to care still continues to be a challenge for our members. Medication adherence also continues to be a challenge. There's barriers like logistics, lack of transportation, health literacy barriers, and then once again, access to care are all ongoing barriers that our members are experiencing. Also, engaging our high risk and underserved populations is another obstacle. And many times, as we've identified this, many of our members have significant SDOH needs, such as transportation limitations, access to food, access to affordable housing, and all of that is a direct impact on their health care. The nice thing is the Vheda team has a process to screen for those SDOH needs. And then in collaboration with our internal care coordination team, they have the ability to work together, remediate those barriers, which is really imperative to members leading their healthiest life.
Thank you, Beth. Dr. Woodhouse, I would propose the same question to you from the gaps and obstacles that providers see.
Yeah, sure. Before I answer that question, I bet that your examples were great. And the initial concept of care teams was, from a provider perspective, was always insular within the system. It's because of systems and technologies like Vheda Health that it allows us to really understand what the care team is all about. It's the plan, it's the technology, it's the community, it's the patient and the system. And so I think your example illustrates that, is why we will now see that care teams in these models, these extended models, will really impact outcomes in care. Back to your question, I'm sorry, Bill, but I just thought that was an important point from a provider
Thank you.
perspective. But beyond blood pressure and hemoglobin A1C, for me, the biggest gaps are in longitudinal engagement and mitigating upstream risks. We still underperform in areas like medication adherence, behavioral health integration, and social determinant insight. The things that truly drive outcomes but are not really captured in traditional metrics, especially in the office setting or the hospital setting. So for health plans and providers, closing the gap means connecting clinical data with real-world signals by utilizing management technologies like Vheda Health, because we have then that other piece of information, the nutrition, the stress, the mobility, adherence patterns. That's important for the longitudinal metrics. So we can intervene before the metric that we're measuring, whether it's blood pressure or adherence to medication, it begins before it moves in the wrong direction. So to me, the next frontier in quality isn't new labs or diagnostic tools. It's really continuous data-driven connection to how people actually live and manage their conditions from day to day in a real care team model that has internal and external members.
Thank you very much. I think overhearing both of this is it's now more of a collaboration between the health plan, the member, and the providers, just getting all three bridging these gaps to really improve the care and how members are receiving their care, and to close these care gap closures and produce better outcomes. Thank you all very much for that insight. Let's look at the Vheda Health Blueprint for Success. Sheila, could you walk us through Vheda's repeatable, scalable model and how provider integration drives success?
Yeah, for me, as a clinician, as a researcher, as someone who's been intimately involved in data and technology, it was refreshing and very, I was optimistic and excited about Vheda Health because all of those factors were taken in consideration during the initial design, not an afterthought. So it combines the predictive analytics, the behavioral engagement, the care coordination, live and in digital formats, into a closed loop system. Every member touch point, whether a text, a call, an interaction with a live patient, which is critical and a key differentiator, or a reminder, feeds back into that real-time data layer so that flags from clinical and behavioral risks before they become quality gaps. What makes it scalable to me is the automation with precision. I had referenced that earlier. The same framework can be adapted to diabetes, hypertension, COPD, or maternal health because it's customizable by population. One size doesn't fit all. The provider integration for me is really what unlocks the full value. I'm a provider. When data insights flow back to physician and care team in an easily integrated model that doesn't disrupt care in real time or workflows, that turns the reactive care into proactive partnership with, again, this extended care team with the patient being in the center. Clinicians can now see which patients are trending off track, what interventions may or may not be working, and where to focus that next recommendation. So to me, that alignment between plan, platform, technologies like Vheda Health, patient and providers is what will drive that measurable improvement in stars and HEDIS and overall patient experiences.
Great insight. I really appreciate that, especially from the provider side. Beth, I'd love to hear your insight, especially from the health plan side, and how this blueprint has helped you in improving outcomes for your members.
Yeah, great. Thanks, Bill. So, here at Blue Cross Blue Shield of Illinois, we actually did operationalize the Vheda program. And like Dr. Woodhouse mentioned, we use our integrated data to really run and drive our care and disease management programs. Those programs are really informed by many different data sources, such as EMR feeds, claims and encounters we receive, the immunization data that we receive, pharmacy data, all in which, when you combine all of those components, lead us to and really help us understand our members' care gaps and where their healthcare needs are. We really use that data to identify disparities, such as those that might exist either in rural areas or hard to reach areas. One example of that is that, we targeted COPD and asthma in downstate Illinois. Or like in New Mexico, where we have expanded the Vheda program, they do community events. We have a food as medicine program. And we have started now conducting health literacy education opportunities as well. The nice thing about the Vheda model, it allows for flexibility, it's customizable, and it really allows us to tailor to each population's unique needs. Because as you could imagine, the population in Illinois, whether it's in the Chicago area or downstate Illinois, or the New Mexico area, where there's a lot of rural areas as well that may not even have, internet access, that the ability to customize this program specific to those members' needs is really what ensures our success.
Well, thank both of you very much for that insight. Let's look at the key takeaways. Give us one actionable piece of advice before we go to our Q&A that would be key takeaways for each of you. Dr. Woodhouse, I'll start with you first.
And I'm going to have to give you two because I can never give one thing. So the first would be treat quality as a strategic growth factor, not just a compliance metrics. I think that's important for providers to hear, health systems to understand. And remember, patient-centered care is also understanding and leveraging data from environmental, social, psychological, financial, and other health drivers that impact their decisions and their health. And what a better partner in plans and Vheda Health to make that happen.
Beth, your perspective?
Great, thanks, Bill. Yeah, so from a health plan perspective, choose some of your high impact measures, things that have a lot of significance in downstream effects like CBP or A1C. One of the key components is start early. You can't start a quality program at the end of October or November and expect the ability to move the needle by December 31st. So start early, start planning, start early, and really then embedding that program into your daily organizational processes. In addition, make sure you partner wisely, embrace those scalable models, and then always follow through with some sort of rigorous analytics and tailor those interventions specific to those populations, like I said, such as the hard to reach population or the rural areas.
Well, thank both of you for all of these great insights and your thoughtfulness of answering the question. In today's session, we hope we've shown how managed care contracts, value-based provider agreements, quality ratings, tightly linked to outcomes and long-term financial strengths can improve outcomes, improve ROI, especially in the hard-to-reach populations. I think we bridge business and clinical strategies. Thank both of you for that input. How to help deliver not just compliance, but real improvement for members and communities. As Beth, I think you said, it's not just about the CVP and the A1C, but it's the social determinants of health and Dr. Woodhouse, how we bring this collaboration together, I think is great. But I think key resources will be shared after the webinar. All studies and visuals will be sent and downloaded blueprints for success for practical references and intermediate applications in your organization. Next slide. So live poll questions. Let's close with this. How this looks. How is your understanding of how to address your health plan ability to improve whole person health outcomes through virtual care, especially for rural and hard to reach communities across Medicaid, Medicare, and SNP change from today's sessions? Significantly improved, somewhat improved, no change, still need more information. Well, I want to thank Dr. Woodhouse and Beth for sharing your valuable perspectives, and thanks everyone who joined today. Scan your QR code to join partner community. Following materials and CMS alignment guides will be sent.
We'd like to invite everyone to submit any open questions to the panel here. So we'll just give everyone a couple minutes to jump in and ask those questions. And as those questions are coming in, we'll proceed with having them answered. Well, as we're waiting for them, one of the things that we learned from our polling question is that from the beginning towards the end, we saw an increase in the percentage of our attendees who now have a better understanding of how to address their whole person health outcomes for their hard to reach population. So, as we're thinking about this, Beth, Dr. Woodhouse, one of the things we always come across is the provider health plan partnership. And so one of the things that we would love to hear from each of you is, what are some of the ideal ways that provider and health plan partnership can work better together so that we can achieve better clinical compliance, which ultimately then leads to these better quality outcomes? Beth, we'd like to start with you, if that's okay.
Sure, absolutely. Thanks, Shamit. So, from a health plan perspective, we actually, it took a couple of years in Illinois. We built very solid relationships with our providers. I managed a quality team here. That was our 100% focus. That's what we did. We worked directly with the providers across the entire state of Illinois. And we did a lot of education, Shamit, on things like what is HEDIS, because, when you look at, like I said, there's a very different knowledge base we found between providers that are in the Chicagoland area versus the more rural areas. And so we did a lot of education around what is HEDIS, what do the HEDIS measures mean, why are they important, and then we also did like a HEDIS 101, and then we did a HEDIS 102 education sessions. Then we did like, what are the changes in HEDIS, because every year the HEDIS measures change. Some are retired, some are added, some may just change some of the metrics. So we did a lot of education with the providers. We had monthly JOCs with them. And in my current role, Shamit, I actually manage the healthcare transformation collaboratives here in
Mhm.
Illinois, which is a conglomerate of multiple provider groups working across the state in different regions. So there's multiple HTCs, as I call them, and they are made up of different provider groups who have no affiliation legally, but they are all working together to achieve a single goal, and they are focused on different things. Some are chronic care, some are maternal health, some are behavioral health. It just depends on each TC's makeup and what they've decided to focus on for these members in these regions. And I have, once again, monthly JOCs with them. We share data. We have bi-directional referrals going from the HTCs to our internal, whether it's care coordination or our behavioral health care coordination teams. And we're
Mhm.
really trying to get to some of these members who have a lot of challenges. Like I said, many of our members have a lot of SDOH needs, and either we might have the resources, or maybe even the HTC or the provider groups across the state have available resources. And so the ability to share those resources really is closing the gap on many of the members' healthcare overall.
Got it. So what I heard there was an increased focus on provider education, right? It sounds like, the more
Yep.
that we have an opportunity to educate our provider community, uh, there seems to be more openness, towards the closure of these clinical care gaps and improving the quality scores. Have you seen that from your perspective, Beth?
Yeah, pretty significantly, Shamid, over the years. Equality doesn't get moved overnight, so it's really
Mhm.
the ability to get that data over to the providers and make sure that data is actionable. Providers, when a member walks into their office, they don't have an hour to sit down and go through an EMR and necessarily figure out what the member's care gaps are all the time.
Mhm.
They need to be able to have actionable insights to that data and what that member might need when that member walks in the door.
Mhm. Okay. All
I'd
right.
like to add one thing to that too.
Please.
With the Vheda phone, and remember, Beth and Dr. Woodhouse could answer both, is that with them being able to store their readings, be it blood pressure, weight, or glucometer, or whatever, getting that information back to the provider, Beth, I would ask you maybe how your providers look at it, but Dr. Woodhouse, managing and taking that, as you said, the member-centric model first. Be great to hear how you all both looked at that, because now the data is there for them to see it both ways.
Yeah, I will say, so I'll answer that, Bill. But Beth, what Beth has spoken about is regarding education is key. Our physicians are humble, and we can have to continually learn. And our focus is often on learning the medical pieces and staying updated, and
Right.
having other people coming in. No one doesn't want to miss certain things, but you don't always have the time to curate it. So partnering with plans who then have that focused education that ultimately impacts, that's that care team, the cycle. It's not one directional, it's the bi-directional and around. And the wonderful thing is the education is power and key, but then how do you execute that and implement that? And I think that's, for me, where Vheda Health technologies and comes into play, because we could have the best intentions and we could want to do these things, but then how do we accomplish those things without adding burden and heaviness into our day to day?
Mhm.
And this then leads into your question, Bill. The first question I asked, you remember, I said, okay, it's great that we gather this information, but then how does it get fed back such that it's not a burden?
Correct.
Physicians are already tired,
Right.
with these EMRs, et cetera, and we can get these fragmented pieces of information. It's no different than when a patient brings in their blood pressure cuff and we have to click through all the things over the course of time. Have we really gotten all of the data points over the time period that allows us best to manage? With the system, the technologies that are in place, the workflows that you have in place, getting that output in a very practical way that shows, again, longitudinal results and data, and then where there are inflections of what could be impacting those outcomes or that information is key. And it's easy to look at, it's quick to look at, it's easy to scan within your EMR and be part of your note. And so I think that's where, Beth, the education is critical, but then your technology allows us to implement and execute on what we know we should be doing in a very easy way.
You know, you made a key point there, Dr. Woodhouse, around the idea and the focus on longitudinal engagement. And, you know, that is a foundation. I think, you know, whether you're a provider, whether you're a health plan, whether you're an organization such as Vheda, we're all striving to achieve. And so one of the big components of that is social determinants. So we're looking at the Q&A panel here, and, you know, we see a question from Miss Veronica. And, you know, to this group, she's asking, you know, what is the best SDOH support program you've found for your members to be offered through a community-based organization? So Beth, Dr. Woodhouse, I'll give you you know, a little bit just to think about that, and then, you know, provide you with an opportunity to share your response to Veronica and the rest of the group.
Well, I can quickly share because
Please.
I work with, I've done technology digital for a long time, and I've worked with many companies over the years. And I think that is the missing piece, but it's not just any technology. Vheda Health to me is unique in the fact that, again, thinking about it from a physician perspective, from a patient perspective, from the plan perspective, and having that continuous feed and closing the loop. But as importantly, or what to me a key value proposition, because not all patients or systems are as the tech literacy, the ability to navigate, even if they have a phone delivered. What do I do? What do I download? You fill in all those gaps, and that's what's wonderful. And I think that for the live component, because as great as a phone is, as great as an app is, it's just like I have a personal trainer apps. I still have a personal trainer at times because I need that human touch, because again, there's nuances that application may not pick up in how I'm doing my squats or how I'm doing my, whatever I do, the crazy things that I do. It's not picking up some of my personal nuances. Whereas
Sure.
I have a live person who feeds into and watches me. And they were like, okay, she'll position your feet this way, do this, because you're going to get more output and a better outcome if you do it that way. And that's just an exercise. So why wouldn't we apply that also to our health? So that for me is a very easy question.
Yeah. I really love what you said there around the better output, which leads to a better outcome. And I think that human touch piece is something that we as an industry sometimes lose sight on, where, you know, we tend to see the shiny new object. You know, for right now, that in the industry seems to be AI. And everyone seems to be talking about how AI is going to transform or replace, you know, the human touch capability of the healthcare sector. But, you know, what we see, and I use this analogy a lot, even with my kids, which is that there's really two industries, if you were to look at, where the human touch component just continues to be very, very vital. One of them is healthcare, and the second is education. And if you want to produce the output that creates the best outcome, you have to combine the two in a way that really, really creates unity, but will result in ultimately the outcomes that we all want. So Beth, with that, I'd like to turn it over to you for, you know, same question, just to repeat it one more time. What is the best SDOH support program you've found for your members to be offered through a community-based organization?
So Shamit, that's kind of a little bit difficult question, because one of the things that we're doing, we're piloting different things within our organization. I think right now we're looking at various closed loop referral systems. There are 3 of them that we're working with, depending on you know, what the program or SDOH need is. We are piloting them with some of the CBOs. Some of the CBOs use them, but they haven't, or they've been only maybe using one piece of them. They haven't been really looking at like reporting that closed loop. So it's really not a one size fits all, because this is such a relatively new concept of addressing SDOH needs. Now that we know all of the negative impacts that, you know, not having things like food, access to healthy food, transportation, housing, how those really impact a member's healthcare. I think that's one of the things that we're kind of still trying to flush out a little bit, Shamit. But I think first off, the ability to identify what those SDOH needs are, because they are going to be very different across the different populations. And the nice thing about the Vheda team is that they do that screening, and then they can work with our internal care coordination team. Once again, like Dr. Woodhouse said, it really is a team of individuals that are coming together to address those needs. So more to come on that as we kind of get through some of these initial things with these CBOs and really defining those closed loops. But the ability to
Yeah.
address those, do the assessment, figure out what those SDOH needs are, get them those resources, and then note it that it's actually a closed loop. That's where it really comes as a comprehensive care model.
Yeah. So it sounds like here, if I were to summarize, the best way to achieve this is a model that, one, identifies what those core SDOH needs are from the member, and then personalizing that in a way that allows us, whether you're the health plan or whether you're the provider, to essentially close those SDOH barriers. And then what is essentially the icing on top is by adding the human element of it, using technology to really drive that that output, as Dr. Woodhouse said, which ultimately leads to the outcome, which in this case would be the closure of those SDOH gaps. Is that fair?
I think
Yes.
that's fair, and I think it's an understatement because typically, most systems now have their screening tools. Again, everything's a checkbox. Do you feel insecure about your food? All these things, and some patients don't really, the value of having an individual is that, like we spoke about, how someone may identify it in Baltimore City may be different than someone identifies in Illinois, and having live individuals that are sensitive to those geographies and the populations and the chronic disease that's being addressed will allow the language to meet such that the appropriate data, meaning answers to those which SDOHs really are impacting them, is that much more robust. I always tell people, to your point about algorithms, the input is more critical, or is so critical for the right output. So if we're relying on people to identify what that is being honest and clicking through, identify their SDOH, we've missed a large population. So I think you adding that live touch in will allow the right questions to be asked to really get to the root cause of things. I'm a question, why is this? Why is that? Why is that? And eventually a live person can get to that. The chatbot can over time, but it may not elicit the same trust and comfort as a live person. So that's why I say it's a
Doesn't give
little
that
understated.
empathy.
Well, you're right, Bill, but it's funny. There was just a release, and I won't say what country it's coming out of, but that they just launched a hospital with AI robot doctors because supposedly they programmed empathy. Now, I don't. I mean, it's true. But we'll have to see how that evolves. I would put the onus of responsibility is going to become on physicians that are not robots to maintain their compassion and empathy so as not to get wiped out.
Well, Beth, I'd like to ask another question. That you have partnered with Vheda for a period of time, and Dr. Woodhouse brought up a great point about technology, and when the phones are sent out, it's individualized for the comorbidity, but having the one touch, for pharmacy and provider, and how's that interacted, and what kind of responses are you getting from your members in the underserved population on the ease and simplicity? Because we don't want to make it complicated. And as Dr. Woodhouse said, sometimes technology is technology, but we want to make it simple so people can actually utilize it.
Yeah, and actually, Bill, I'm going to go back to the prior question real quick because something Dr. Woodhouse made a comment about, is, the human touch, and that element is to me very critical in that, a member, if the question is, does the member have food insecurity? The member might not think they have food insecurity because there's a convenience store across the street. And so they get chips and pop and, fast food type food from that facility versus truly a food insecurity, which is access to actually healthy foods. So I think that's also where the human element comes in, is the ability for members to understand what access to food is versus a true food insecurity may not be the same thing. So I just wanted to throw that out there real quick. And then Bill, to answer your question, the members have given us very, very good feedback. One of the things that we have a monthly JOC with the Vheda team. Our care coordination team attends it. Our medical directors attend it. And they actually give us things like the member satisfaction survey information. We go through a lot of that. We go through some of the results. We go through like a specific measures that they're targeted and focused on to see the month over month improvements for those members. And the members are very, very satisfied. They really like the program, Bill. My previous experience that I shared during the webinar really goes to the depth and breadth of the Vheda program and the impact that that type of digital literacy and digital programming has on our members.
Mhm.
Thank you.
And actually, to this point, so one of the themes that we're hearing, as we're reviewing these Q&As, is the focus on community, is the focus on access to live individuals. So Connor, he asked a follow-up question actually related to SDOH. And he made a comment to start, which is, sometimes I feel like we put the burden of outreach on our provider offices. Are there any creative ways for the payer to support members and help them engage in care? And the reason why is, it's often a difficult dynamic because the provider office will likely have a better idea of the SDOH barriers to care than we do to support members getting access to care. So both Beth and Dr. Woodhouse would love your commentary on Connor's question here.
Dr. Woodhouse, do you want me to go first?
I think so. If he's
Okay.
specifically asking the plan, I'll let you.
Yeah, about the health
take
plan.
that.
That's what I thought. So, one of the challenges from a health plan is when you look at, especially on the government side of business, where we have contracts. The contracts are pretty prescriptive with who we need to manage. Typically, they're deemed to be high or moderate risk members. Connor, some of those members are very difficult to reach. You're right. I think sometimes the burden does get put onto providers. Now, that being said, at least at Blue Cross Blue Shield, we do a lot of community events and we do reach out to members. And these community events are across the entire state of Illinois. Sometimes we are focused on members with specific conditions. We actually have we actually do outreaches from the plan perspective to these members to invite them to come to these events. In fact, we're having one actually in the Vermilion County region in November, and it's around Thanksgiving. So we're doing things like turkey giveaways where we have member incentives. They have a mobile food pantry coming where they can actually get low cost food, to support that. And this is where I think also closing some of those SDOH needs, closing those gaps in care. We're actually partnered with a very large provider group in this region. So they're actually going to have about 8 different providers there. We're scheduling appointments for those members to get in to see those providers. And that when the members are there, they will close all their gaps that they can. Obviously, we're not going to have like a mobile mammogram. So if they're going to need a mammogram, they're going to have to do referrals for those. So there are the little nuances and things like that. But there's a lot of opportunity. It's not just about throwing a gap list at a provider and expecting them to close all those gaps. It really does have to be a community focus. It has to be working with some of your CBOs, working with your providers, working with your internal care coordination teams. We're going to have care coordination there. So it's really closing a joint effort across different venues and different individuals that will actually help move that needle.
I thought that was a great answer, Beth, because again, it goes back to internal and then who's on that external care team.
Yep.
I'm on the board of the American Heart Association in Washington, Greater Washington, D.C. And ironically enough, a Care First event at the arena was last weekend. And so it was really about looking for their members, looking at really where there were gaps that could be filled in education. I spoke to some, but it was really, I explained, they promoted a lot of the event through some of the provider offices to do that work that he's talking about. Because again, providers can't do everything. You know, some of us are there to support the communities in that regard, but it is, the plan took the initiative. They had the food as medicine, and so they were healthy food. They had the right vendors to understand blood pressures. They get flu shots and all these wonderful things. They're all making it fun. But that takes the burden off of a physician in that specific area, because then the patients go back with that information and the dialogue in that office changes. It becomes less directive and more of bi-directional. So I think, again, the team members are some of these community organizations that partner often with the plans in order to bring these events to fruition. So that's a great value for providers, so we don't feel so overwhelmed with having to do all the work.
And Dr. Woodhouse, I'm going to make another comment to that. I think it's also important that we're bringing care to where the members are. You know, we can always expect members to go to the provider's offices, and many of these might either have transportation issues, but if you're bringing the care to where the members are, odds are
That's
that
right.
they're going to get that care. So like, and at Blue Cross, we have we have a care van, so they can do immunizations on those care vans, and they can go to different locations. So they can support the immunization or vaccination efforts that, you know, maybe the providers either can't do or something like that as well. So I think that's also something that Blue Cross does very well, is we are also
Yes.
bringing a lot of the care to where the members are. We're meeting them as opposed to expecting them to go, you know, meet like I said, to go to a provider's office.
No, I think that's key. And it's, to your point, it's fit for purpose. And I was telling them there, I said, you know, the setup, we were in downtown DC, is different than it would be in even, you know, Anne Arundel County. And this is all within the same, you know, driving distance. You know, I laugh because we had go-go bands there, downtown DC. We may not have go-go bands out in the middle of, you know, Western Maryland. So, but you meet people where they are, you get them excited, like you said, all the monitoring. But I think the plans are in the right position to connect those dots with those additional community supports for providers' offices, as well as innovative technologies such as Vheda.
Very, very, very good. So we have a third question along the same theme of what we've been discussing here. It comes from a Miss Carol Franklin, and she said, with all the changes that are coming to Medicaid, how are we going to address overall food insecurities, not just the food deserts?
Yeah.
Yeah, Shameen, I think that's kind of one of those $1 million questions.
Sure.
What, you know, and one of the things that we have found is it seems like food, you know, access to healthy food is becoming more and more of a challenge. So, and it can't be like you said, it can't be just well, here's a box of food and then you're good to go,
Right.
because that doesn't address a long-term need or make it
Mhm.
sustainable. So I think this is where either partnering with things like food banks or, you know, a lot of churches sometimes have a lot of those, you know, food things where people can drive up and get food. I think trying to navigate that and figuring out who's doing what, and this may be where like the CBOs are going to come into effect. And even though some of those closed loop referral systems where you can go into a system and see who's doing what in various regions of the states or something like that, and where you could partner with them to you know, address some of those food as medicine issues.
That's,
We only have 2
yes.
minutes remaining, so just wanted everyone to have the knowledge that it's 2 minutes.
Okay, thank you. And so to kind of piggyback off of what Beth said, I think not just it's longevity, and you start then looking at, we think about innovation in the form of technology, but there's also entrepreneurs who are thinking about these things. How do you put healthy things in the corner stores or that are in neighborhoods and communities? And so when you start thinking about how do you support those type entrepreneurs to do those things. I think there's a company I just recently connected with here, the People's Market, and trying to work with them that deal with farmers direct, and how do you meet people where they are with a couple fresh options that maybe that the plans and these programs will allow them to use vouchers and things for, even if it's one, or I always say something is better than nothing. 1 or 2 healthy from the earth meals a week are better than McDonald's every day. I shouldn't say McDonald's. Well, fast food every day.
Well, I want
Absolutely.
to turn this back over to Bailey. Thank you all very much, Dr. Woodhouse and Beth. Appreciate it, and everyone that joined the session today. Bailey?
Yeah, thank you so much to everyone today for putting on a great presentation, and thank you to Vheda Health for sponsoring today's webinar. I want to thank you all for attending on behalf of RISE. Just a reminder, you are going to receive a webinar survey that's going to pop up on your screen. If you could just take a moment to complete that, let us know how today's webinar was. We would truly appreciate that feedback. And then just remember, tomorrow you'll receive an email from RISE with today's recording with all this great content, as well as access to the slide deck. So that concludes today's webinar, and thank you guys so much for attending, and thank you to our sponsor, and we look forward to seeing you all next time. Bye, everyone.
Thank you.
Thanks, everyone.
Thank you, guys.